Welcome to video 6 of the MRCP PACES series. This is Dr. Owais. The abdominal station is one of the most rewarding in PACES. Because the cases are consistent, the signs are reproducible, and the examination follows a logical sequence that, once mastered, becomes completely automatic. In this video, the full abdominal examination routine step by step, the 5 most common cases: hepatomegaly, splenomegaly, hepatosplenomegaly, renal transplant and polycystic kidneys, and ascites. How to present your findings with a unifying diagnosis and a detailed breakdown of all 4 mistakes. The instruction card will say something like, "This 52-year-old man has been referred with abdominal swelling. Please examine his abdomen and present your findings." 6 minutes. You need to complete the full examination, inspection, palpation, percussion, auscultation, and completing signs in that time. Positioning is critical in the abdominal examination and is assessed as part of Skill A. The patient must be lying flat with one pillow under their head. Their arms must be by their sides, not behind their head, which tightens the abdominal muscles. The abdomen must be fully exposed from the xiphosternum to the pubic symphysis. Maintain dignity by keeping the groin covered with a sheet until you need to examine that area. If the patient is not positioned correctly, ask, politely, before you start, "Would it be alright if I just lay you flat with your arms by your sides? I want to make sure I can examine you properly." This is a patient welfare point, and it is a technical necessity. You cannot feel a spleen or palpate a kidney properly through a tense, poorly positioned abdomen. General inspection from the end of the bed. Take 10 seconds. This is where the abdominal examination begins and where examiners start watching. Look at the patient overall. Do they look well or unwell? Are they jaundiced, yellow skin and sclera? Are they in pain, cachexic, pale? Look at the abdomen. Is it distended? Diffusely, suggesting ascites, obesity or bowel obstruction? Or locally, is there visible peristalsis? Visible pulsation in the epigastrium suggests an aortic aneurysm? Any obvious mass? Look at the skin of the abdomen. Surgical scars. A right subcostal scar, Kocher's incision, suggests previous cholecystectomy or liver surgery. A midline laparotomy scar. A left iliac fossa scar with a bulge suggests renal transplant. An inverted Y scar suggests previous aortic surgery. Striae, purple striae in Cushing's syndrome. Dilated veins, caput medusae radiating from the umbilicus, indicates portal hypertension. Look for a stoma, colostomy or ileostomy. Note the site, whether it is spouted or flat, and the contents of the bag. Look at the flanks, fullness of the flanks, the earliest sign of ascites. Narrate. On general inspection, the patient appears comfortable at rest. The abdomen is mildly distended with fullness of the flanks. I note a left iliac fossa scar, consistent with a renal transplant. The abdominal examination is rich in peripheral signs, and they are assessed as part of Skill B because they help build the diagnosis before you even touch the abdomen. Hands. Look for clubbing. In a liver disease patient, clubbing suggests cirrhosis or chronic liver disease. Leukonychia, white nails, hypoalbuminemia from liver disease or nephrotic syndrome. Terry's nails, white proximally with a pink-brown distal band, also liver disease. Koilonychia, spoon-shaped nails, iron deficiency, which may point to chronic blood loss or malabsorption. Dupuytren's contracture, thickening of the palmar fascia, strongly associated with alcoholic liver disease. Palmar erythema, redness of the thenar and hypothenar eminences, a sign of chronic liver disease. Caused by hyperdynamic circulation from excess estrogen not metabolized by the failing liver. Asterixis, ask the patient to hold both arms outstretched with wrists extended. A flapping tremor, liver flap, suggests hepatic encephalopathy from liver failure. Wrist, feel the radial pulse. Note rate and character. Arms, look for spider naevi. Each one is a central arteriole with radiating capillaries, like a spider. Press on the center. If it blanches and refills from the center outward, it is a spider nevus. More than 5 spider naevi above the waist is significant. They occur in the distribution of the superior vena cava territory. They are a sign of chronic liver disease. Face, look for jaundice in the sclera. Always check the sclera in good light, pulling the lower lid down. Xanthelasma, yellow plaques around the eyes, suggests hypercholesterolemia, seen in primary biliary cholangitis. Parotid enlargement, bilateral, a sign of alcoholic liver disease and also seen in cirrhosis from other causes. Mouth, angular stomatitis suggests iron or B12 deficiency. Glossitis, Phaeter hepaticus, a sweet, musty smell on the breath in liver failure. Neck, look for lymphadenopathy. A Virchow's node in the left supraclavicular fossa, Toisier's sign, suggests intra-abdominal malignancy with spread to the left gastric lymphatics. Chest. Look for spider naevi on the chest and upper arms. Gynecomastia, breast enlargement in males, a sign of excess estrogen and liver disease. Loss of axillary hair, also estrogen excess. Now the abdomen itself. Palpation is the most important step and the one most commonly done incorrectly. Before you touch, ask the patient, do you have any areas of pain or tenderness? If yes, start away from that area and approach it last. Watch the patient's face throughout palpation, not your hands. The face tells you about pain. Kneel or sit at the level of the patient's abdomen. Your hand should be flat and warm. Light palpation first. Using the flat of your fingers, gently press in all 9 regions. Right hypochondrium, epigastrium, left hypochondrium, right flank, umbilical, left flank, right iliac fossa, suprapubic, left iliac fossa. Assess for tenderness, rigidity, guarding. Feel for any obvious masses. Deep palpation. Repeat in all 9 regions with deeper pressure. Identify any masses. Note their location, size, surface characteristics, consistency, tenderness, mobility, and whether you can get above and below them. Liver. Palpate for the liver, starting in the right iliac fossa. This is essential. A massively enlarged liver can extend to the right iliac fossa, and if you start at the costal margin, you will miss it. Use the radial border of your index finger, placed parallel to the costal margin. Ask the patient to breathe in. The liver descends on inspiration, and you feel the edge against your finger. Move your hand progressively up toward the costal margin with each breath. If you find a liver edge, note how many centimeters below the costal margin in the mid-clavicular line. What is the surface? Smooth, irregular, nodular. What is the consistency? Soft, firm, hard. Is it tender? Is the edge sharp or rounded? Pulsatile liver. A liver that pulsates suggests tricuspid regurgitation. Tender liver suggests hepatitis or cardiac failure, congestive hepatomegaly. Spleen. Palpate for the spleen, starting in the right iliac fossa and moving toward the left hypochondrium. This is the most commonly missed organ in PACES. The spleen enlarges toward the right iliac fossa, so if you start at the left costal margin, you will miss a large spleen. Use the same technique. Radial border of the index finger, parallel to the costal margin, asking the patient to breathe in with each step. Key features of spleen. You cannot get above it. It moves under the costal margin. It has a notch on its medial border. Feel for the splenic notch. It moves diagonally toward the right iliac fossa on inspiration. It is dull to percussion. You cannot ballot it. Kidneys. Use bimanual ballotment. Place one hand in the flank posteriorly and one hand anteriorly. Push upward with the posterior hand. The kidney bounces against the anterior hand. Normally the kidneys are not palpable, except in thin patients. An enlarged kidney can be balloted. This distinguishes it from the spleen. Aorta. Palpate in the epigastrium with both hands. Feel for a pulsatile mass. If you feel expansile pulsation pushing your hands apart laterally, this suggests an aortic aneurysm. Note, do not confuse transmitted pulsation, where the aortic pulse is felt but the hands are not pushed apart, with true expansile pulsation. Bladder. Percuss or palpate in the suprapubic region. Percussion and auscultation confirm your findings. Liver dullness. Percuss from the right lung resonance downward. The upper border of hepatic dullness is normally at the 5th intercostal space in the mid-clavicular line. Then from the right iliac fossa upward to find the lower border. Hepatomegaly. The liver is enlarged beyond the normal span of 12 to 15 centimeters. Splenic dullness. Percuss over the left hypochondrium. The spleen should not be percussible unless enlarged. Use Traube's space, the area of gastric resonance bounded by the left costal margin anteriorly, the lower ribs laterally, and the diaphragm superiorly. Normally resonant. Dull Traube's space suggests splenomegaly. Ascites. This is critical. Every candidate must examine for ascites in an abdominal PACES case. Shifting dullness. Percuss from the umbilicus outward to the flanks. If the flanks are dull, mark the point where the note changes from resonant to dull. Then ask the patient to roll toward you, wait 5 seconds, and repercuss. If the dullness has shifted, become resonant where it was previously dull. This is positive shifting dullness, suggesting ascites. Fluid is mobile and redistributes with position. Fluid thrill. Only use this test if shifting dullness is positive or if you suspect massive ascites. Place one hand flat on one flank. Ask the patient, or an assistant, to place the ulnar border of their hand in the midline of the abdomen. Flick the opposite flank firmly with your fingers. If you feel a fluid impulse transmitted across the abdomen to your resting hand, this is a positive fluid thrill, indicating large volume ascites. The midline hand dampens fat transmission. This distinguishes a true fluid thrill from obesity. Let's move to auscultation. Listen for bowel sounds, normally heard as gurgling every few seconds. Absent bowel sounds suggest ileus. Tinkling high-pitched bowel sounds suggest obstruction. Bruits, a systolic bruit over the aorta suggests an aneurysm. A bruit over the liver suggests hepatocellular carcinoma or alcoholic hepatitis. A renal bruit, heard over each renal angle, suggests renal artery stenosis. How to present abdominal findings, one summary sentence. Then peripheral signs, starting from the hands and working up. Then abdominal findings, palpation, percussion, auscultation. Then completing signs. Then your conclusion, a unifying diagnosis. Then investigations. Here is what this sounds like for chronic liver disease. On examination of the abdomen, I found signs consistent with chronic liver disease, likely secondary to alcohol. In the hands I found leukonychia, palmar erythema, and Dupuytren's contracture bilaterally. There were multiple spider naevae over the chest and upper arms, more than 5 in total. The patient had mild gynecomastia. There was no jaundice or asterixis. On abdominal examination, the abdomen was mildly distended with fullness of the flanks. The liver was palpable 5 centimeters below the right costal margin in the midclavicular line. The surface was firm and smooth. The edge was blunt. Percussion confirmed hepatomegaly with a liver span of approximately 18 centimeters. There was shifting dullness present, consistent with ascites. The spleen was not palpable. There was no evidence of a renal transplant scar or organomegaly on the left. There was mild ankle edema bilaterally. These findings are consistent with chronic liver disease, most likely alcoholic cirrhosis, given the Dupuytren's contracture and parotid enlargement. I would like to confirm with liver function tests, coagulation screen, albumin, and abdominal ultrasound with Doppler. Practice that until it flows naturally. Summary first. Peripheral signs, abdomen. Conclusion. Investigations. Case 1. Hepatomegaly. An enlarged liver, palpable below the right costal margin in the midclavicular line. The normal liver span is 12 to 15 centimeters. Above 15 centimeters is hepatomegaly. When you find hepatomegaly, characterize it precisely, and then think about what type of liver this is. Smooth, firm hepatomegaly has different causes from hard, irregular, nodular hepatomegaly. Smooth hepatomegaly suggests hepatitis, viral or alcoholic, right heart failure causing congestive hepatomegaly or early cirrhosis. In right heart failure, the liver is typically tender and pulsatile. Hard, nodular, irregular hepatomegaly strongly suggests metastatic disease, secondary deposits in the liver from bowel, breast, lung, or prostate primaries. Always feel carefully for nodularity. Run your fingers across the liver surface. Hard hepatomegaly with a firm, irregular edge suggests hepatocellular carcinoma. Causes to know for the examiner: infective, hepatitis B and C, infectious mononucleosis, abscess. Neoplastic metastases, HCC, lymphoma. Metabolic alcoholic liver disease, NAFLD, hemochromatosis, Wilson's disease. Cardiac, right heart failure, Budd-Chiari syndrome. Hematological, myeloproliferative disorders. Presenting, I found hepatomegaly. The liver edge was palpable 5 centimeters below the right costal margin in the midclavicular line. The surface was smooth and non-tender. The edge was sharp. These findings are consistent with hepatomegaly. In the context of this patient, I would consider alcoholic liver disease, viral hepatitis, or right heart failure. I would review the liver function tests, viral hepatitis serology, and arrange an abdominal ultrasound. Case 2. Splenomegaly. The spleen is not normally palpable. When it becomes palpable, even just tipping the fingertips below the costal margin, it is already significantly enlarged because the spleen must increase to twice its normal size before becoming palpable. The key features of the spleen on examination: you cannot get above it. It emerges from under the left costal margin. It moves diagonally toward the right iliac fossa on inspiration. It has a notch on the medial border. Feel for this. It is pathognomonic of spleen. It is dull to percussion, unlike a kidney. You cannot ballot it, unlike a kidney. Trial-based space is dull. Grading: splenomegaly. Mild, palpable 1 to 4 centimeters below the costal margin. Moderate, 4 to 8 centimeters. Massive, more than 8 centimeters, extends past the umbilicus, or toward the right iliac fossa. Causes by size: mild to moderate, portal hypertension, cirrhosis, portal vein thrombosis. Infection: EBV, malaria, endocarditis. Autoimmune: rheumatoid arthritis, Feltes syndrome, SLE. Massive splenomegaly, a favorite examiner question. The causes of massive splenomegaly are limited. Chronic myeloid leukemia, myelofibrosis, malaria, visceral leishmaniasis, and Gaucher's disease. Presenting. I found splenomegaly. The spleen was palpable 6 centimeters below the left costal margin, moving toward the right iliac fossa on inspiration. There was a palpable notch on the medial border. Trabe's space was dull. The spleen could not be balloted. These findings are consistent with moderate splenomegaly. In this clinical context, I would consider chronic myeloid leukemia, myelofibrosis, or portal hypertension. I would review the full blood count and blood film, and arrange an abdominal ultrasound. Case 3. Hepatosplenomegaly, enlargement of both liver and spleen. When you find both organs enlarged, the differential narrows significantly, because the conditions that cause both to enlarge simultaneously are a specific subset. Common causes: portal hypertension from cirrhosis, the spleen enlarges due to congestion. Hematological malignancy, chronic myeloid leukemia, lymphoma, myelofibrosis. Infectious mononucleosis, EBV, malaria, visceral leishmaniasis. Storage diseases, Gaucher's disease, Niemann-Pick disease. Hemolytic anemia, the spleen works harder to remove abnormal red cells. On examination, you will find both a palpable liver edge and a palpable spleen. Characterize both surface, consistency, tenderness, size. Look carefully at peripheral signs: lymphadenopathy, lymphoma, pallor, hematological disease, jaundice, hemolysis or liver disease, bruising, coagulopathy. Presenting. I found hepatosplenomegaly. The liver was palpable 4 centimeters below the right costal margin, firm and smooth, and the spleen was palpable 5 centimeters below the left costal margin, with a palpable notch. There was no jaundice, lymphadenopathy, or stigmata of chronic liver disease. These findings are most consistent with a hematological cause. I would consider CML, myelofibrosis, or lymphoma. I would request an urgent FBC with blood film and arrange an abdominal ultrasound. Case 4 covers 2 related renal cases: renal transplant and polycystic kidneys, because both involve finding an abdominal kidney. Renal transplant. The transplanted kidney sits in the iliac fossa, usually the right iliac fossa in most centers, but can be left. You will see a curved scar, a hockey stick or J-shaped scar, in the iliac fossa. The kidney is palpable as a firm, non-tender mass in that region. It is retroperitoneal. You can get below it, but not behind it. Look for signs of the underlying cause of renal failure: diabetic stigmata, peripheral neuropathy, retinopathy, lipodystrophy, hypertensive retinopathy changes, signs of autoimmune disease. Look for signs of immunosuppression: Cushingoid appearance from steroids, thin skin, bruising, hirsutism, gum hypertrophy from cyclosporin. Look at the other kidney site. Is there a previous nephrectomy scar? Are the native kidneys palpable? Look for a fistula in the arm, arteriovenous fistula, for dialysis, even if the transplant is functioning. Note whether it has a bruit and a thrill. Presenting. I found a well-healed curved scar in the right iliac fossa, consistent with a renal transplant. On palpation, a firm, non-tender mass was palpable in the right iliac fossa, consistent with the transplanted kidney. There were no signs of acute rejection. I noted Cushingoid features suggesting current steroid therapy. There was no peripheral edema. I would like to check the blood pressure, urine dipstick for proteinuria, and review the renal function. Polycystic kidney disease, adult ADPKD, autosomal dominant polycystic kidney disease, presents with bilateral enlarged, irregular ballatable kidneys. The kidneys may be enormous, filling the flanks bilaterally. Key findings: bilateral flank masses. Ballatable, you can get above them. Unlike spleen, the masses are bimanually palpable. The surface is irregular and bossylated due to the cysts. May be non-tender or mildly tender. Look for associated features: hypertension, check blood pressure. Liver cysts, hepatomegaly may be present. Berry aneurysms, ask about headaches or family history of subarachnoid hemorrhage. Mitral valve prolapse, associated with ADPKD. Presenting. I found bilateral flank masses. Both were bimanually ballatable, with an irregular bossylated surface, consistent with polycystic kidneys. There were no signs of chronic liver disease. I noted a raised blood pressure. These findings are consistent with autosomal dominant polycystic kidney disease. I would check the renal function, urine dipstick, blood pressure, and arrange a renal ultrasound. I would also inquire about family history of subarachnoid hemorrhage. Case 5. Ascites, free fluid in the peritoneal cavity. Ascites is not a diagnosis, it is a finding. The examiner will expect you to find it, and then immediately ask about the cause. Common causes. Portal hypertension from cirrhosis accounts for approximately 75% of all ascites. Other causes: malignancy, particularly ovarian, gastric, pancreatic, heart failure, right-sided, nephrotic syndrome, tuberculous peritonitis, Meigs' syndrome, ovarian fibroma with ascites and pleural effusion. Physical signs: inspection, distended abdomen, full flanks, everted umbilicus. The umbilicus everts because the fluid presses outward. If there is a large hernia with an everted umbilicus, the pressure of ascites has pushed bowel through the umbilical ring. Percussion: flanks dull, central area resonant, bowel floats on top of the fluid in the central abdomen. A straight line from umbilicus to flanks marks where the note changes. Shifting dullness: positive. This is the most important clinical test. Always do it. Roll the patient. Wait. Repercuss. Fluid thrill: positive in large volume ascites. The combination of distended abdomen, full flanks, and positive shifting dullness is diagnostic of ascites until proven otherwise. Also look for peripheral stigmata of liver disease, spider naive, palmar erythema, leukonychia, Dupuytren's, if the cause is cirrhosis. Signs of malignancy: cachexia, lymphadenopathy, a palpable mass, ankle edema, hypoalbuminemia from liver disease, or nephrotic syndrome. Presenting: I found evidence of ascites. The abdomen was distended with fullness of the flanks and an everted umbilicus. Percussion revealed central resonance with bilateral flank dullness. Shifting dullness was positive. There were peripheral stigmata of chronic liver disease, leukonychia, palmar erythema, spider naive, and Dupuytren's contracture. These findings are consistent with ascites, secondary to liver cirrhosis, most likely alcoholic. I would confirm with an abdominal ultrasound and arrange a diagnostic acidic tap. Serum ascites albumin gradient greater than 11 grams per liter would confirm portal hypertension as the cause. To distinguish between a spleen and a kidney, remember these key features. The spleen cannot be gotten above and has a notch. The kidney is palatable, moves straight downward on inspiration, and is usually resonant to percussion. Mistake 1. Rushing palpation and missing organomegaly. This is the most consequential mistake in the abdominal station. A candidate who palpates too quickly, too superficially, or who starts the liver palpation at the costal margin rather than the right iliac fossa will miss an enlarged organ entirely. And an examination that misses the main finding, the liver, the spleen, the transplanted kidney, is an examination that fails skill A. The fix: start palpation in the right iliac fossa for the liver. Start in the right iliac fossa for the spleen too, working diagonally toward the left hypochondrium. Palpate systematically in all 9 regions. Watch the patient's face, not your hands. Use light palpation first, then deep. Mistake 2. Not examining for ascites. Candidates palpate, percuss the liver and spleen, and then move on to completing signs without ever testing for ascites. This is a significant omission in any patient with abdominal distension, chronic liver disease, or hypoalbuminemia. The fix: if the abdomen appears distended or the flanks appear full on inspection, always test for shifting dullness. It takes 60 seconds and scores marks. Then offer a fluid thrill test if shifting dullness is positive. Mistake 3. Presenting findings without a unifying diagnosis. I found the liver palpable 4 centimeters below the costal margin. There were spider naive. The patient had palmar erythema. There was shifting dullness. That is a list. The examiner wants you to bring these findings together. These findings are consistent with decompensated liver cirrhosis, most likely alcoholic, given the Dupuytren's contracture and parotid enlargement. The fix: after presenting your findings, always use the phrase, taken together, these findings are consistent with, and give a single unifying diagnosis. Then add the most likely cause. Mistake 4. Forgetting completing signs. Hernial orifices. Genitalia. Rectal examination offer. Urine dipstick. Lymph nodes. These are the steps that differentiate a complete, systematic examination from an incomplete one. Examiners notice when candidates go straight to the presenting summary, without offering to complete the examination. To practice, perform the full routine daily and time yourself. Feel real organomegaly to understand the physical differences. Practice shifting dullness until it's automatic. Memorize the peripheral signs and the causes for every case. Present out loud every time. In summary, follow the full abdominal routine: inspection, peripheral signs, palpation, percussion, and auscultation. Remember the golden rule: the peripheral signs tell the story. The presentation structure moves from the summary to a unifying diagnosis and investigations. Next, Video 7 covers Stations 2 and 5, The clinical consultation.